Chapter 26, Hematologic and Immunologic Dysfunction of the Child. So anemia means we have a decrease in the oxygen carrying capacity of the blood, and it's the hemoglobin, the heme groups, that carry oxygen, remember. So what does this do to the circulatory system? Well, it actually makes the blood more watery. It decreases the viscosity, so you have hemodilution. By doing that, you also decrease the peripheral vascular resistance. It's like you're trying to circulate water as opposed to syrup. It doesn't take as much pressure and it doesn't build up as much pressure. This means you have a lot more blood coming back to the heart. The heart has to work harder because it's got a greater quantity of blood to pump. It also means everything moves with more turbulence, and you often will hear a murmur because of that. You also may develop cardiac failure because of it, and because we're bringing around less oxygen, you're going to see growth retardation in chronic severe anemia. You'll also see on teenagers it'll delay puberty. So let's talk about our blood count, our CBC. We're looking at the hemoglobin, which this is our standard. Remember, every lab may be slightly different out on the ends, but they're in the same ballpark. Your hematocrit is the percent of red blood cells compared to the whole blood. So if you spin it down, how much is red blood cells? It should be about 3 times the number of your hemoglobin, and that's the range we'd like to see. Now we can also look at morphology, so we can look at the red blood cells and see if they look normal. When we look at the MCV, we're looking at the average size. How big is the average red blood cell? If it's small, if it's microcytic, we're going to worry about things like iron deficiency anemia or lead toxicity. If it's large, we're thinking this is the body trying to compensate for something. Is there pernicious anemia or a folic acid deficiency? The MCH, mean corpuscular hemoglobin, estimates or takes the average of how much hemoglobin is on a red blood cell, and it's looking at that in weight. The MCHC is what percentage of each hemoglobin, the average hemoglobin is, of the average red blood cell is hemoglobin. We can also look at the color of the red blood cells. If they're not as red as they should be, they're hypochromatic. We're going to worry about iron deficiency anemia, Cooley's anemia. If they're normal, we're going to worry that this is more of an acute blood loss or sickle cell disease. Here's a picture of what our blood cells should look like. On the left is that nice biconcave circle, which is your red blood cell. In the center is the chunky cell fragment, which is a platelet, and on the right is that bumpy white blood cell. Now, ways we get anemic: we can have decreased production, which is that list on the left. We can lose a lot of blood, which is the center, or we can destroy the cells, which is on the right, and you can see they each have their list of symptoms. The noticeable difference when we are destroying the blood cells on the right, you see that icteric sclera, that's jaundice, that's yellow. So the sclera of the eyes is going to be yellow, and you have the dark urine as you're getting rid of the bilirubin from breaking down the cells. Hepatosplenomegaly, and so different things cause the different ones, and we'll be going through those. So to diagnose anemia, we're going to look at the RBCs, and remember there's slight differences with age, so make sure we're comparing the numbers to what would be normal for that age of that child. But the things we're going to hear from parents, they're going to say, my child just has no energy, they get tired, fatigued so easily, they seem really pale. Those are all symptoms we want to follow up on. Maybe ask about their diet. If they have those symptoms plus a low iron diet, we're much more concerned that this may be an iron deficiency anemia then. If we have a child with severe anemia, we may need to give them oxygen. We're not going to increase the oxygen carrying capacity with the oxygen, but we're going to make sure all of that capacity is being used, so we have every possible hemoglobin carrying oxygen. And a child who's anemic is going to be very susceptible to infection, so we want to ask about that history as well. Now, iron deficiency anemias are most common. We see that most often between 12 and 36 months, and it comes from excessive milk ingestion. Milk is not high in iron, and kids will drink milk instead of eating a meal if they're allowed to. Many do. So they're just not ingesting the amount of iron they need. Preterm infants are even more at risk because they didn't get that maternal iron store because they didn't finish out their time in utero. Adolescents are also more at risk because they're at a stage of rapid growth where they need more iron for building new cells and tissues, and they don't eat well. We have seen some improvements in the recent years, and that's attributed to the WIC program, Women, Infants, and Children, where we're making sure that infants under 12 months are staying on iron-fortified formulas or not getting moved to milk too early. By the way, remember that children under 12 months should not be given cow's milk. They should be on infant formula until they're 12 months old, or breast milk. So if we do have a patient, a child who needs iron supplementation, we need to think about several things. One is GI blood loss. They may be anemic from GI blood loss. Maybe they're allergic to cow's milk, or they were put on it too early, and we've got really irritated GI mucosa, and they're losing small amounts of blood continually. Now, this isn't going to be enough blood to show up in the stool. We're going to have to do stool for guaiac, which is looking for occult blood, tiny traces of blood that are just too small to see but are there. This is also going to give them a little bit of absorption problem for the iron. We want to make sure that they're on iron fortified formulas and the rice, starting with rice cereal, but the infant cereals that are iron fortified. Children who are exclusively breastfed by 6 months probably should be on an iron supplement. When a child's put on an iron supplement, this is not a short-term thing. It's 3 months is a standard treatment. And I know I always had trouble. 10 days of antibiotics. Towards the end, I'd get forgetful with my kids. So you can see this is going to take a lot of teaching with the families to get them to really be compliant. It's just 3 months is a long time, and it's hard to remember to do that. If they're not improving or we're having trouble with compliance on the oral supplement, we can give iron IV or IM. Obviously, that's a lot more traumatic for the child. It's also more painful, more expensive. There are some factors when we do have a child on oral iron. Remember that low pH is helpful. So either between meals, so we've got that gastric acid in there, or with something that's high in vitamin C, such as fruit juice or fruit. Their multivitamins probably will help as well. Meats and vegetables, and those are the things that are high in iron. Cooking in cast iron fry pans. In the old days, people didn't have very much problem with iron because they had those thick, heavy cast iron fry pans, and we don't use those anymore, but those actually added iron into the food, and it was beneficial. So things that are going to decrease absorption are having a higher pH, alkalinity. So you wouldn't want to give it with antacids. Phosphates, which is in milk, decreases it. A number of your cereals, your fruits and vegetables, the type of iron they have is actually a little bit less absorbable than the iron that comes from meats, so it means you need more of them. Tannins, which are in tea and coffee, decrease it. If you just can't pick up anymore because the tissue's saturated, if there is some sort of malabsorption going on, or if there's diarrhea, we've got that whole GI system too irritated to be able to pick it up, or if there's an acute infection going on. All those things will change the absorption. Okay, moving on to sickle cell anemia. This is when the adult hemoglobin is partly or completely replaced by abnormal sickle-shaped hemoglobin. This is an autosomal recessive trait, so remember that means 25% of the kids will have it, 50% will be carriers but not have it, 25% will not be carriers or not have it when you have two parents who are both carriers. It's primarily in African Americans, and actually some areas in Africa have an extremely high incidence. In African Americans, we're talking about 9% of them carry the trait. And then, yeah, in West Africa, some areas are as high as 40%. It's thought it may have started as a protection against malaria. So here's our picture of how that's passed on, the sickle trait and normal hemoglobin. So 1 out of 4 will have it, 1 out of 4 will not have it, not be carrier, and 50% will have be carriers but not have it. This is a picture of what's happening. Those cells sickle and they just don't flow through the micro circulation very well. They clump up. So when you get a clump, blood doesn't move beyond that clump. The tissues past that clump get hypoxic. They're not getting the oxygen they need, and that causes a lot of pain. It causes little micro areas of infarct, of cell death, and you end up with damaged tissues. Typically where we get that damaged tissue, the things we're watching out for, one of the most dangerous is the CVA, stroke. So when that happens up in the brain, in the retinas, so the eyes, the hepatomegaly, so the liver, the spleen, splenomegaly, in the kidneys, and you can get blood in the urine, hematuria. You can also kind of destroy the kidneys a little bit, so you end up with dilute urine, losing that ability to really concentrate it. Abdominal pain, just from, again, areas that are not getting the blood supply and the oxygen they need past the areas that get plugged up. Priapsism, that's a prolonged erection in males, that erection that doesn't resolve, and it can be very painful. Hands, feet, knees, all the joints can become very painful. You can get chronic ulcers. You see down there on the lower leg. I was kind of going down the right side of this picture. You can also have problems in the heart and lungs. Yeah, congestive heart failure. And as those cells clump up, they also break down. So you end up with anemia because those sickled cells get damaged and break, and you don't have enough red blood cells. So that's the anemia part. Now, many things can trigger the sickling of those cells: dehydration, acidosis, fever, hypoxia. All those things will make the cells sickle worse, so you get worse problems. So we want to avoid all those things. And here's just a kind of a tracking down all the different systems that get damaged and how that happens. Here's another picture kind of showing the different areas that are affected.